Welcome, I'm Bryan DenHartog. I'm a orthopedic surgeon in the Minneapolis-St. Paul area here in the United States. I'm here as an invitation from the Carestream company to talk about my experience with the on-site 3D imaging that we just put into our office about 8 months ago in Woodbury, Minnesota. I've been in clinical practice for about 27 years, doing mainly foot and ankle surgery, fellowship training in those areas of sports, trauma, and reconstruction of the foot and ankle. Not until recently have I had the opportunity to be partake in the Carestream technology. Our group, Twin Cities Orthopaedics, purchased one unit, which is in our office in Woodbury, Minnesota, and we're going to be purchasing a second unit for our Eagan office that's opening up in about 1 month. So it's been a wonderful technology for me, and I'm going to share a little bit about why it has, to a certain degree, changed the way I treat my patients and evaluate my patients at office and also post-operatively. So why do I use an in-office cone beam CT scanner? As I said, I didn't really use this until just recently. It was a technology that I knew was out there, but to have a CT scanner in the office was actually quite expensive. Hey, Paul.
There's one of your fans, Hey, bro.
So it's really kind of changed what I do. It's changed the way I see patients. But I use it because we really have diagnostic challenges as foot and ankle surgeons. Dr. Canali here with me is one of my co-fellows way back in the early 90s. But the foot and ankle anatomy is very complex. There's a lot of joints in the hindfoot, namely the subtalar joint, talonavicular joint, and also Lisfranc's joint, that are very difficult sometimes to read on X-ray. How much cartilage is left in those joints. For example, the subtalar joint is a saddle joint, so it is difficult just on a lateral view to see across that joint to see how much cartilage you have and how much is still remaining, or if there's any kind of an osteochondral lesion or failed fusion, etc. So we also treat a lot of common deformities, pes planus, cavus deformities that are really dynamic deformities. So the weight-bearing part of the CT scanner is very important, and that we don't always know from just plain X-rays or MRI scans, which are not dynamic tests, whether we have ligament instability or we have a certain amount of cartilage loss. And the weight-bearing part of this, especially with foot deformity, allows us to evaluate joints with a weight-bearing view to see whether or not those ligaments, such as the deltoid ligament or the spring ligament, are actually stable. And if they aren't, then we'll see that on the 3D imaging or even the two-dimensional imaging on these CT scans that are weight-bearing. So we do a lot of redo surgery, and we've seen a lot of, it helps us to know where the pain is coming from when people have had surgery before. Again, with previous hardware that's been placed or previous attempted fusions, we don't know for sure whether the fusions have healed and if that's the source of pain the patient's had persistent. So again, the CT scan is very important for this, especially the weight-bearing part, to see if there's any residual instability in some of those joints, residual deformity, broken or loose hardware. Again, it gives us a lot of detail to work through all that. So what do I need to make a good clinical decision in a timely fashion is I need to have something that's very convenient for patients. In the past, when I've needed a CT scan or an MRI scan that wasn't in office, I had to write an order and send the patient to another facility and then have them come back at a later date to review those results with the patient face-to-face. So I want something that facilitates a more rapid communication and a patient satisfaction, and that usually is a one-stop shopping kind of thing for patients. They love to be able to go to the office, get the evaluation, get the test that they need, and then go right back to the doctor, talk to them about the results of that, and then make a clinical decision at that point. So it needs to be cost effective as well. I mean, I think a lot of these tests that we do, the CT scans are more informative to us as decision makers than plain X-rays. But again, the cost of just the cost of a regular X-ray is quite a bit higher. Excuse me, CT scan is quite a bit higher than an in-office weight-bearing CT scanner per exam. And so again, I just found that we need to have something that's more cost-effective than the traditional CT scanner. If we had something that's more cost-effective and more convenient, we probably would use it more often and probably have more information to make our clinical decisions. So it's got to be safe for patient. Again, traditional CT scanners are usually quite large machines and a lot of radiation, and that's one of the reasons why we don't get a lot of CT scans is because the vital organs are exposed to a fair amount of radiation. And they need to be high resolution images. I need to be able to see the joints clearly. I need to see the trabecular bone inside the bones that I'm examining. I want to make sure that there's trabecularization across the fusion site if I'm evaluating the patient post-operatively. Again, I want to be able to see around the metal because a lot of these redo patients are patients that have already had surgery that I'm concerned about maybe slow healing or non-healing of a fusion site. I want to be able to see around that hardware, or if an implant like a total ankle is loose, I want to see whether or not if the bone is attached to the metal or not. So the scatter from the typical CT scanner sometimes can obliterate some of that detail. And again, as I said before, the dynamic weight-bearing effect of the CT scan is very nice. Again, evaluating the amount of cartilage loss in joints and also whether or not there's any ligament instability. And again, I've been using this a lot in my practice for evaluating my fusions, especially my subtalar and midfoot joint fusions and also second, third TMT joint fusions. I get enough detail from these even within 8 to 10 weeks to know whether or not there's been some trabecularization of the bone across the fusion site. So again, for patient convenience, it's same-day service. The scan takes about 5 or 10 minutes, usually less than 10 minutes. Usually I'll have, it takes about 10 to 15 minutes for my computer to render the images so I can view the images on my computer screen in the exam room. It's the same day decision making. Patient doesn't have to go to another facility or return a visit to review the findings. And so economically for the patient, they don't have to take another half day out of work or several hours out of work at least. So the cost, again, the cost is approximately 25 to 30% less than a standard multi-slice CT scanners. Less radiation, probably 4 times less radiation than a regular CT scanner because of the protective mechanism, the shielding that they have around the foot and ankle, and it goes all the way up to the knee as well. So if you do want to do certain type of software devices where you actually can make a cutting block for a total ankle, there's that technology out there as well. This scanner can do that as well. You don't have to send them to a big CT scanner. So what's different about a cone beam compared to a regular traditional CT scanner? You can see that the traditional CT scanner is just a narrow slice through the patient, is imaged, and then with a cone beam there's a bigger area, more of a cone-shaped area of radiation that comes out of the patient, so you get a large area detection images with extended volume, and it just turns into a better resolution picture, and I'll show you some examples of that in just a moment. So here's one of my cases. It just kind of demonstrates some of the resolution that I get from my little CT scanner in my office. And here's a TMT fusion. This is second TMT and third TMT fusions. You can see the trabecularization across those fusion sites. That's what I want to see to make sure when I tell the patient to start full weight bearing or start to increase their activity or go back to work, that I'm pretty confident that 50% or more of that fusion is already trabecularized and fairly solid. So it really does help me look around the hardware. I can see the images or the trabecular bone very well. So it just gives me that valuable information. And this is the frontal view. You can see, so the image, again, the resolution's high enough so that I can clearly see that there's a good connection between the two fusion surfaces. So it just gives you a little bit more kind of a contrast between traditional CT and the cone beam. You can see how much more resolution or detail that you can see in the bone and also in the joint with these type of images. A little bit of a blow up there of that. This is also a wrist application. Of course, it's an extremity scanner. So you really can get a great view. Again, really the detail. This looks kind of foggy, and that's a much more clear image. And that's pretty consistent with what I'm seeing in the lower extremity too. It's just really, the resolution is very impressive. Much better than the traditional CT scans that I've been getting. Again, it's another coronal view through the ankle and subtalar joints, the hind foot. So the weight-bearing advantage, again, I talked about this before. The ligamentous laxity issue is really an issue with us. Most of us know when there's a posterior tibial tendon rupture in a patient, but is the deltoid intact? Is the swing ligament intact? And again, the weight-bearing part of an examination is very important to kind of help us sort out as surgeons. Is just a reconstruction with some osteotomy is going to work with the posterior tibial tendon reconstruction, or is the deltoid so loose and the spring ligament so shot that and the laxity on weight-bearing so extensive that fusions are probably a better option for those patients. So then again, the loss of cartilage space, degrees of deformity can be clearly seen with the weight-bearing part of this technology. So here's a non-weight-bearing CT scan and then a weight-bearing CT scan. You can see that this looks like there's a lot of cartilage left, but again, the weight-bearing, the dynamic test shows that there is no cartilage left in between the two bones. Same thing on the lateral view. Again, the weight-bearing, this is another patient with actually quite a bit of ligament laxity on the plain x-rays or plain CT scan. Non-weight-bearing, you don't really see much deformity, but when they put the weight on, you can see the subluxation, the calcaneocuboid joint is quite impressive. So so that's the advantage of a weight-bearing CT versus non-weight-bearing. It becomes a dynamic test. So this is a 3D rendering of a CT scan, but then you see the images going through. You can see the detail, every little fragment. You actually see the articular cartilage on top of those fragments as well. And it really helps me decide whether or not this is a primary fusion patient or maybe a primary open reduction internal fixation. Again, for fracture evaluation and healing, again, it's so easy now to get a better feel for pushing these complex fractures, tri-mel fractures with a lot of displacement. Just we got any fragments in between the major fragments that may prevent reduction. I get a really quick evaluation of where the syndesmosis is at. Again, it's just literally a 5-minute scan for the patient, and I can show them the images right away afterwards to just show them where the deformity is and explain to them what we need to do, what the problem is, and then how we're going to fix this thing. So again, the time convenience of this is just, it's impressive for patients. So you can also evaluate, this is just a 3D rendering of some of the scans that the software has the capability of doing that. Just see the progression of fusion. Again, patients just love to see this. And again, with the lower cost, it really does, it makes it more doable for the patient. And again, your patient satisfaction scores will go up. So again, this trabeculization thing, I think, I'm in a group now where there's a real research infrastructure and prospective studies are really important to us to make sure that the treatments that we're doing are very effective and patient satisfaction and reported outcomes are positive. And so I think the understanding of how these patients are healing after surgery are going to be very important for our studies. We evaluate fusion techniques with different implants, different ways of doing things. We want to make sure that we can report the benefit of these things, especially when the new technologies come out. And again, for reporting this, the journals now, that especially Foot and Ankle International, it's really pushing us to get more CT scans after surgery to really prove that these fusions are really solid. And plain X-ray, again, notorious for midfoot and hindfoot not being very accurate as to whether or not there really is a fusion there. So again, they evaluate the extent of trabecular bone bridging for all these studies that we're doing. The metallic artifact reduction software that this system has improves the visualization around hardware. I'll show you a couple more examples of that as well. Again, as we talked about, I can really see those trabeculae very, very nicely on these scans. It's better for the complex joints that we talked about. And I have a lot more confidence now telling my patients at 10, 12 weeks to start weight bearing fully at work or just at play. So here's a little example of the metallic artifact reduction that I'm seeing. You can see that basically the software negates all the hardware in the areas of the fracture and through this area, so you can see a better get a better evaluation of whether or not there's a connection between that fracture, the fracture sites. And you can do the same thing with fusion, as I'll show you a little bit later. But you can see the scatter that you get with kind of a regular CT scan. You can see the scatter there and the blackness that occurs there, the shielding of the X-ray by some of the hardware. So this is a much more consistent view of what's going on inside the bone. So this is a patient that I saw last fall. Had a previous attempt at a subtalar fusion, 2 screws placed from the heel up into the talar body. Had persistent pain in the medial lateral aspect of his hind foot. He had a clear non-union on the CT scan that was done. And then post-operatively, once I did another grafting procedure and added some extra fixation, a staple and another screw, you can see that now he has trabecularization across the fusion site here and here. And so his pain was gone at 8 weeks. I scanned him and I got this image. And told him, okay, you can go ahead and full weight bear, and it's with great confidence that over 50% of that fusion is solid at this point. So that's the kind of results that I can see, the kind of information that I can get from this machine to make my clinical decisions. So here's just another preoperative evaluation. A patient had a failed opening wedge supramolar osteotomy for a cavus deformity. You can see the X-rays don't really give you the information that you need to say for sure with any great confidence how much of that osteotomy is actually healed. And the CT scan with the MAR software in play, it gives me a very clear view that the majority of that osteotomy is not healed. You can see the sagittal view on the right side is clearly there's no connection or trabecularization across that osteotomy site. So here's another example of the metallic artifact reduction software. Here's one where I'm trying to evaluate more around this area to see whether or not there's been adequate healing to a TTC fusion with bulk allograft. And again, here's without the MAR and here's with the MAR. You can see that there's much less scatter associated with that. So again, another benefit of that kind of software. Here's a failed total ankle arthroplasty, or I should say a persistently painful total ankle. And I didn't know for sure. I knew the tibial component was loose. I just didn't know about the subtalar or the talar component. So I wanted to get a CT scan. There's a lot of metal in that ankle joint. I wanted to see whether or not there was any still bone connection between the talus, the remaining talus, and the talar component, and whether or not there was any fracture underneath that talar body as well. And so with the MAR software, it's really a nice view. You can see that there is connection of the bone, and that was actually confirmed by a 3-phase bone scan that there was no uptake on that image. So it's very helpful. So I guess kind of in summary, and I'm certainly going to take some questions if you want to ask that, but it really helps with imaging of those really complex joints of the hindfoot and the midfoot because of all the overlapping structures. I really enjoy the ability to quickly do a weight-bearing CT scan. It allows me visualization of the joints under a natural load and get a dynamic test or stress of those joints. And then also, again, because of the high, superb bone visualization of complex fractures, I can see where the main fracture fragments are, but also the small pieces, and also evaluate the cartilage surfaces as well. So again, the metallic artifact reduction software really does give me a lot of confidence when I'm looking around, especially my redo surgeries that come in that have failed a previous operation. It's really nice to be able to look around that hardware to see, is there a fusion there or is there not a fusion there, or how much of it is fused. So again, it's a convenience for the patient to get the diagnosis and the treatment recommendations in a single visit. Provides a faster and increased patient experience and satisfaction. So for me, the images facilitate patient consultation and agreement on a treatment plan. Again, it's when you work that into your patient clinic workflow. Now I know, my staff knows that certain new patients that have just plain x-rays, but they have a lot of deformity, that I want a standing CT scan, so they bring the patient in a half an hour early before they're supposed to see me. So they work that into the flow, and the x-ray techs are ready to do the scan. And so by the time I see them in a half an hour, then the whole CT scan is rendered, and I can just look at the images on the screen in the exam room with the patient. And so it's just, it saves me time in the office because I have all the information that I need right there, all the detailed information to make the diagnosis and develop the treatment plan. So initially it kind of disturbs your workflow because you don't know for sure if everybody's going to get a scan. But again, it's just literally it's 20 feet down the hallway to the CT scanner from my office where I see patients. And again, the patient satisfaction has been very high. So.